44.5, and thank you everybody for sharing, but just to back up a sec, we can kind of talk through it here, as the doctor orders vancomycin 500 milligrams infused 5 milligrams per kilograms per hour. Patient weighs 98 pounds, and our supply is 500 milligrams in 100 milliliters of normal saline. It's how many milliliters per hour will you administer via the pump, so we know what units we're looking for. It says round the answer to the nearest tenth place. So remember, tenth place is one place to the right of the decimal. And the smart pumps, even the ones in lab, although I've been hearing they've been getting some newer pumps, they can go to the 10th place if needed. So looking at our numbers here, we know milliliters per hour is what a pump thinks in. We can look at what we have that's in milliliters, that'd be the 100. And then we've got this guy, milligrams per kilogram per hour. And that could be tempting to do off to the side and then plug that number in. But the hazard with that is if the weight of the patient ends up being a run-on, once you put pounds into kilograms, that can throw off your answer. So we'd suggest how I did it here, it's just kind of plug it into the equation, and how I kind of wrote, you could write kilograms over hour on the bottom. I just put them next to each other because they're kind of both bottom units, so to speak. But we'd start with our 100 milliliters. We know we need milliliters, but it was connected to the 500 milligrams. If we compare back here, that's why I like writing the units off to the side. Oh, we don't need milligrams, but we saw the 5 milligrams per 1 kilo per hour was there. So 5 milligrams on top, bottom here, that'll cancel. And then we have kilograms per hour. We know we don't need kilos, but we do need hour, so we can cancel. Kilos will be on top of the next one that was connected to pounds, because 1 kilo is 2.2 pounds. And then we want to get rid of the pounds. We have the patient's weight in pounds. And the weight technically could be over nothing. It could be over X. I just tend to put a 1 there, so there's something there. Multiply across the top, across the bottom. And when it's in the 10th place, we want one place to the right of the decimal in the answer. So for today, we will be covering hematology, HIV, and oncology. Now, the question often comes up, why did we put 3 topics in 1 unit? And it's not because we don't like you. I've gotten told that on occasion. The thing is, there are many specialties in nursing. And I mean, the 3 biggest ones are what you're going to see in 3rd semester with 2301, PEDS, Psych, and OB, and those are definitely the largest, but they're not the only specialties. So with this unit, hematology, HIV, oncology, and the next unit with breast and reproductive health, those are also specialties in nursing that we're kind of introducing at this point. If you were to specialize in any of those fields, you would get a lot more specific training. But we're kind of taking an overview approach to this, and this is why they're put together. So when you're studying, kind of keep that in mind. And in a few places in the online lecture, it's stated, you'll need to know this, you won't need to know that. There is some guidance in the online lectures when you're studying with those. And believe it or not, we're already getting close to the final exam. So we would suggest at this point, if you haven't already, taking like an hour a week and going back over the earlier material now. So by the time you get to that point, it's not a mad cramming session. Especially now you guys have gone through, 5 tests worth of NCLEX style questions, and you've done mastery quizzes. And kind of with that experience that you got under your belt now, looking at the earlier material where you didn't have that experience with navigating the questions and what to look for. And or if there was a unit that didn't go particularly well on the exam, again, with the benefit of what you know now, going back over that material just to refresh your memory. So when you get to studying for the final exam, it's a little fresher in your memory. Hard to believe we're already talking about the final exam. But wait, as far as this unit goes tonight, I'll talk a little bit about each topic, and then after each topic, do a mini case study. And I uploaded the mini case studies in Word doc form to Blackboard, but they'll also be in the online lecture right here. Well, in this online lecture. So, first, hematology. And with hematology, there's some overlap with oncology. Some blood conditions or hematological conditions are also considered cancers or are symptoms of cancers. So you might hear the term hemonc quite a bit in the hospital, and that's because if we were to split off the non-cancerous blood conditions, they almost wouldn't be enough to have their own department. So a lot of times we'll just combine hematology and oncology, but not every hematology condition is a cancer or is tied to a cancer in some way, but many of them are. So with this chart, I just like to show kind of how the terms are all connected, because we'll be talking a bit about different, move the chat box over here, the different categories, and just to show what goes with what, because it can be easy to lose track of things as we're going through it. I want to talk about red blood cells first. And these are the cells that help carry oxygen around the body. And we have two, versions of imbalances with red blood cells. We have anemia and polycythemia. And when you're coming up to these terms when you're sitting or on the test, some can look kind of complicated, and it might be like, what even is that? I don't remember reading it. It wasn't even in the book. Yes, it was. But anyway, it might help to try and take the word apart, like polycythemia. Down at the bottom, for example, poly is many, cyto is cell, and we'll talk as we go through the different terminologies. That just might help if you come up to it and you're like, what was that? I don't even remember what that was. Try to take the word apart and see if that can give you some clues. Like anemia is here. A is often used to mean without in healthcare speak. So an anemia is a lack of something. And so women typically, except for one, sickle cell. But iron deficiency, pernicious, and aplastic anemias are all lacking something. So overall, our treatments are going to focus on replenishing what's missing, whether through foods or a supplement, and or could be both in some cases. So when you're looking at the anemias, I try to see, make a chart or a list or something that shows what makes them different, like what signs and symptoms, how could you tell them apart? Because we never ask about that, right? But with example, I'll come back to sickle cell in a second, but iron deficiency anemia, some of the symptoms can include weakness, pallor, fatigue, reduced exercise tolerance, and fissures at the corners of the mouth, because iron is part of what makes hemoglobin, which is what helps carries oxygen around the body. And so management of these conditions is going to be to increase the intake of iron-containing foods. It could also be a supplement, but some of the foods could be red meats, especially organ meats, egg yolks, kidney beans, green leafy vegetables, and raisins. Some of the iron supplements could include ferrous sulfate or ferrous gluconate. Often the gluconate is one that has a coating on it for the stomach, so it's not quite as harsh. But there are some side effects of the GI system when you're taking an iron supplement. These can include nausea, vomiting, diarrhea, or constipation when in the book, but I've seen more the constipation with iron. Indigestion, and to reduce GI distress, we can teach the patient to take the iron between meals, but it's going to make the stool very dark and sticky. And so often I would feel like as a nurse would be like, okay, here's your iron supplement to build up your anemia, and here's the Colace to combat the side effects of the iron. Or some type of stool softener is often given as well. However, with dark, sticky stool, another thing that could cause that is blood in the stool. So if someone is started on an iron supplement, they may also have an order to send a stool sample just to check for bleeding in the stool, like occult blood or hidden blood. just to make sure that they didn't somehow start a GI bleed at the same time they were taking the iron. I mean, it could happen, and we just want to make sure, we're not making an assumption as a nurse that it's the iron. Then pernicious anemia is low vitamin B12, and I'm not sure how pernicious got to mean vitamin B12, but yes. Symptoms of that can include different ones for mild or severe. So for the mild first, we might see pallor or paleness in the skin, jaundice, yellowing of the skin, glossitis, or a beefy red tongue, fatigue, and weight loss. Severe pernicious anemia symptoms could even mimic a stroke. They could also include paresthesias or poor balance. So management, if this is low vitamin B12, would be to replenish the vitamin B12. And so this could be supplement-wise, either through an injection or a nasal spray. Or we could have them increase the intake of foods that contain vitamin B12, like animal proteins, fish, eggs, nuts, dairy, beans, fruit, and citrus fruit, and green leafy vegetables. The last type of anemia we have here, other than sickle cell, is aplastic anemia. And just aside, this often occurs with pancytopenia, and there's a slight difference, although some sources may use the terms together. But just to clarify, pancytopenia is one of those words we can take apart. Pan meaning many, cyto meaning cell, penia meaning low, many cells low. And this is where you can have red blood cells, white blood cells, and platelets all being low. So somebody with pancytopenia, they're going to be very, very ill. More ill than somebody who just has like one of the blood cells low. That's pancytopenia. Aplastic anemia is one disease process that can lead to pancytopenia. And it's a little bit of a distinction, but it can be important because pancytopenia could occur with different disease processes. The one we're looking at right now is aplastic anemia. So symptoms could include fever, fatigue, or weakness. And those are kind of similar, the fatigue and weakness, what we saw above. But this type of anemia could have bleeding tendencies because, remember, all of the blood cell types are low. And malaise or dyspnea. So management would include a bone marrow transplant, trying to give the body a kickstart, monitoring for anemia because of the low red blood cells, monitoring for infection because of the white blood cells, and watching for bleeding because of the low platelets. This patient may also be on neutropenic precautions, again, to protect them from staff or visitors bringing a microorganism into them. Because if all their blood cells are low, they're going to be very vulnerable to many things, including infection. So sickle cell anemia, you may see in some sources it referred to sickle cell disease because in some ways it's similar to an anemia, but it's not actually an anemia in the way like iron deficiency is low iron. Sickle cell, we don't lose the cells per se, but they change shape. And so in sickle cell, they have an abnormal type of hemoglobin called hemoglobin S. That's not in all of their red blood cells, but it's in some of them. And it depends on the person and the severity of the illness. Some may have more, some may have less. When that hemoglobin S, I'm going to go forward for a second, is triggered, their cells will change. They go from this nice round red blood cell that we'd expect to this kind of curved or sickle shape. That's how it got its name. But the thing is, these sickled red blood cells don't fit through the blood vessels, and so they can kind of form a clump together or an occlusion. And under the right conditions, someone with sickle cell disease can develop what's called a vaso-occlusive crisis. Vaso like vessel, occlusive occlusion of what we've got going on over here. And crisis because it's an emergency for their body. Depending on where the occlusion is, you could have a significant part of their circulation cut off. And so their lack of oxygen to the tissues is going to register as pain, and they may or may not have external symptoms. In some cases, the area where the occlusion is may appear reddened or swollen, especially if it's in one of the joints, but it may not be, not in every case. And unfortunately, this is where sometimes some patients come to the ED, seeking help. And if they don't have any visible external symptoms, they are not treated, unfortunately, for their pain. They may be mistaken for drug seekers. So we need to be aware of this as nurses, that a patient with this condition could have pain, 10 out of 10 pain, and not have any external symptoms because everything's happening inside. But if we don't treat their pain and break up the occlusion, then their tissues could actually die because of the lack of oxygen. And this next picture is not, you don't have to know all of these, just to show you how widespread some of the complications could be. I mean, we could even have involvement of the brain, the lungs, eyes, the lungs and heart could be affected, abdominal organs, kidneys, genital organs, the whole skin, bones, and joints. Especially the joints are good places for the occlusion to occur. So the whole body could potentially be involved. Probably not all at once, but it could be anywhere in the body, although it's often in the joints. And so these patients are going to be in intense pain, likely a 10 out of 10. And we would want to work on breaking up the occlusion. And there are 3 priority interventions or pain management. Like we said, they're going to be 10 out of 10. Oxygenation is, again, their tissues aren't getting adequate blood flow. And breaking up the occlusion and hydration. So we want to treat the pain with IV medication. This is going to be especially narcotic like morphine or Dilaudid because the intensity of the pain is likely going to be on a PCA pump where the patient can control the administration. We do not want to use Demerol or hydroxyurea, as this can lead to leukemia. Hydration, either by the oral or IV route, depending on how the patient's doing, could help to reduce the duration of the pain because dehydration could lead to sickling. So that could be a cause of the crisis. And oxygen will help the patient breathe more easily, but the patient with sickle cell is at greater risk for bacterial infection because their spleen could be impacted by the disease. And so we want to teach the patient how to recognize potential triggers and hopefully avoid them if at all possible, but at least know what their symptoms look like in the early stages so they can seek care as soon as possible. They're going to be at risk for heart failure related to the anemia. Their extremities could be cooled to the touch with weak pulses and slow capillary refill. Their skin could either be pallor or pale, or cyanotic even because of decreased perfusion. And they could have major organ damage to the spleen and liver from hypoxia, lack of oxygen, and ischemia. And kidney and urinary changes could lead to chronic kidney disease and joint or back pain. So they could have quite a lot going on with sickle cell. So we also have polycythemia. Down here, didn't forget about this. So anemias in general, except for sickle cell, are a lack of something. Polycythemia is going to be too many, kind of the opposite. We can tell that with poly meaning many, cy meaning cell. And it's where we have an increased number of red blood cells, white blood cells, and the platelets. in the blood, and the lifespan of these cells is going to be shorter, and the red blood cells are going to release potassium because more potassium lives inside the cell than outside the cell. So then that can cause some issues, especially with the heart, if we've got extra potassium floating around. And the sheer number of cells that we have in the blood could cause the blood to become very thick and viscous. So it's not going to flow through the body very well and is more likely to clot. The patient with polycythemia vera is going to appear with a dark purple or cyanotic or flushed appearance because of the lack of oxygen in the thick blood, with distended veins due to the blood volume and viscosity. They may have intense itching caused by the dilated blood vessels and poor perfusion. Vascular stasis, or stationary blood, can cause thrombosis within the smaller vessels, and depending on how big the clot is, where it's located, that could lead to hypoxia, anoxia, no oxygen, and later to infarction or necrosis. And tissues most at risk for this problem include the heart, the spleen, and the kidney. And as we've studied those, we definitely need those organs for the body. So how could we treat this if we have too many cells? We wouldn't want to replenish it like we do with the anemias, because that would make the situation worse. So we want to take out some of the excess cells. So someone with polycythemia could get blood work done often to have some of the excess cells drawn off. Phlebotomist takes some blood, and then the blood may be separated out into the fluid and the cell part, and then the plasma, the fluid part, could be reinfused into the patient, so they have the fluid volume but not the extra cells. But this could have to occur several times a week, like 2 to even 5 times a week. These patients may also be on anticoagulants because, like we said earlier, they are going to be more prone to developing a thrombosis from the venous stasis. That's kind of primary polycythemia. There is a secondary type I don't think is mentioned in your book, but I think it is in the online lecture, where if a patient is in a hypoxic area or like an area with often high altitude, in some places the oxygen may be thinner, so to speak, might not have as much oxygen as at lower levels. So the kidneys could stimulate more erythropoietin to produce more red blood cells to try and circulate more oxygen, especially if this is new to the person. So this could result in the patient having a flushed appearance because of increased red blood cells, but that is secondary polycythemia. The primary one is what we went through, where we have too many of many cells, red, white, and platelets. But these cells are going to be short lifespan, and so especially the red blood cells are going to release potassium into the bloodstream, which can cause a lot of issues. So that's the red blood cells. We've still got 2 more types. Pictures for sickle cell again. All of the things that could lead to. So, look, the white blood cells can also have their own imbalances. This is where some of these are also known as cancers or can overlap in oncology. So leukemia is the first issue with white blood cells, and it is known as a malignant blood disorder of unknown cause. So malignant meaning cancerous, but we don't know necessarily what causes it. So we can have either an acute or chronic type, but there's also 2 types, myelogenous or lymphocytic. And you don't necessarily need to know what the difference between those 2 are, but you might see a reference as you're studying. So you could have acute myelogenous, acute lymphatic, chronic myelogenous, chronic lymphatic. Symptoms, though, of leukemia overall would include infection because their white blood cells aren't working correctly. Again, we can have high immature white blood cells. And the immature cells aren't ready to work yet. And they're not going to be able to do much. The patient is going to be more prone to infection, fatigue, petechiae, or kind of the pinpoint bleeding, pallor, bruising, excessive bleeding, and weight loss. Management could include neutropenic precautions, again, protecting the patient from having infection brought to them, bleeding precautions, a stem cell transplant to try and give the body a kickstart, and medications like anti-neoplastics or colony stimulating factors. You also, with white blood cells, can develop a lymphoma, which is a cancer of the lymphoid tissue with an abnormal overgrowth of lymphocytes, especially in the lymph nodes that you can have scattered throughout the body, or the spleen. There are two types of lymphomas, either Hodgkin's or non-Hodgkin's, and how that's determined depends on a specific type of cell related to lymphoma. That's called a Reed-Steinberg cell. And if the Reed-Steinberg cell is detected in the blood, then it's considered a Hodgkin's lymphoma. If there's no evidence of Reed-Steinberg cells, it's considered a non-Hodgkin's lymphoma. Symptoms, though, of lymphoma overall would include swollen, painless lymph nodes. And we said this would be an overgrowth of the lymphocytes, especially in the lymph nodes. Night sweats, anemia, which could lead to fatigue, and leukocytosis, which could lead to fever and infection. The management could include chemotherapy and radiation, and that's because this is considered a cancer. We'll talk about chemo and radiation when we get to cancer, to the oncology section. In multiple myeloma is the third type of imbalance of the white blood cells. It is also considered a cancer. This is a cancer of the white blood cells that involves mature B lymphocytes called the plasma cell. This plasma cell typically secretes antibodies, but multiple myeloma results in reduced production of red blood cells, white blood cells, and platelets. Symptoms of multiple myeloma could include bone pain, pathological fractures, or fractures that don't need an injury to occur. They could just occur from spontaneously or even just turning over in the bed because their bones become that fragile. Fatigue, bruising, and infection. And fatigue, because they could have less production of red blood cells, bruising, less production of platelets, and infection because of less production of white blood cells. Management can include anti-neoplastic drugs, back brace, especially to help with the fractures, force fluids, and monitor for calculi in the kidneys because they're going to tend to have increased serum calcium from multiple myeloma. So you'll be glad to know the platelets section is a little shorter. So platelets, we're going to primarily be concerned with issues with bleeding because we're going to have an abnormal number of platelets. Now this is where taking the word apart, though, could come in handy because thrombocytopenia. Okay, well, what's that mean? Well, thrombo, that's like thrombus. Oh yeah, that could be related to platelets. Cyto is cell, penia is low. So platelet cells low. Also with thrombocytopenia purpura, to me purpura kind of sounds like purple, the color of a bruise. If we've got too few platelets, you're going to be more likely to bleed or have a bruise. And this would result in increased risk for bleeding, so nursing priority bleeding precautions. Because the macrophages are actually destroying the platelets, so this is where the body's attacking itself. Hemophilia is another condition of platelets. It's abnormal, but it's an inherited condition, so there's a genetic factor here. involving a lack of clotting factor 8 or 9. And this would mean that the body, if it detects an injury, could form an initial fibrin plug, but just the beginning stages. It would never solidify into a stable clot to help form or to help stop bleeding. So they'd be more prone to continue bleeding, and it would be very hard for them to heal from an injury. And at the bottom here, we have HIT, or HIIT, heparin-induced thrombocytopenia. And this is where the patient given heparin has an abnormal reaction to it. We give heparin to help reduce the chance of blood clots forming. So you might think, well, if they're having a bad reaction, they're forming a clot instead. That's not exactly it, but heparin-induced thrombocytopenia, remember, thromboplatelets, cytocell, is low. Okay, so if someone who has this has a reduced number of platelets, well, that's not exactly it either, unfortunately. But for someone who has heparin-induced thrombocytopenia, they do have a drop in their platelet count after heparin administration, but this leads to the body developing abnormal clots, because the platelets release microparticles which activate thrombin, which leads to a thrombosis. Now, you have to repeat that on the test. So they have an abnormal reaction to heparin, and the biggest risk factor would be the patient receiving heparin for more than 1 week, which, especially our post-surgical patients, they're often getting heparin once, if not twice a day. So the treatment, though, would involve stopping any heparin. This would include a heparin drip, a heparin sub-Q injection, any heparin flushes through an IV. You got to take it all away. And we would likely, though, administer an alternative coagulation because they still could be at risk for developing a clot, especially our post-surgical patients. But we want to use something that would not drop the platelet count any further. And well, why don't we give them some platelets? Because that can actually trigger a hypercoagulation state where they form a whole bunch of clots because they're already have an abnormal reaction, and then we put in a bunch of more platelets and the body can just go haywire. So typically we just remove all the heparin containing products and use another type of anticoagulant and kind of let then the heparin cycle itself out of their body and make sure it's on their chart so that they would not get heparin in the future. So I'm going to do the first case study here. So hematology. I'm going to involve a patient named VL. And she is a 29-year-old African-American female who comes to the emergency department seeking treatment for an acute episode of sickling. So she has a diagnosis of sickle cell anemia. So she complains of really bad pain in her arms, legs, joints, and abdomen, and it hurts when she takes a deep breath. And she was diagnosed with sickle cell anemia when she was 4 months old, so quite young. And she's only had a few episodes of sickling in the past 4 to 5 years, so it's relatively well controlled. But her last episode was about 6 months ago, and she's had a cold for the last several days, and has also had a sore throat and a cough. And she says it's been hard to swallow with her sore throat. So we go to gather more info, and she ranks her pain a 9 on a scale of 0 to 10, with 0 being no pain and 10 being the worst. And she's not currently taking any medications. She does not smoke, but occasionally drinks alcohol when out with her friends. Physical assessment data: mucous membranes dry and pale. Her skin turgor is fair. BP 108 over 68. Heart rate 94, temp 102 Fahrenheit, or 38.9 Celsius. Breath sounds bibasilar in each base. We're hearing crackles. Heart sounds are within normal limits. Abdomen is soft, non-distended, but painful with palpation. No, she doesn't have bowel sounds. And ankles, knees, wrists, and elbows are swollen, painful, and warm to touch. So, two factors in her history and assessment that could precipitate or cause the sickle cell crisis are, let's back up here. Anything from this first scenario part here, if you think maybe you have an idea what could have triggered her crisis? Yep, she has some type of respiratory issue, currently described as a cold, and infection could trigger her to develop into the crisis state. And how about from her assessment data? Anything else? And she's having a lot of pain. That could be from the crisis, though, because her the areas past the occlusion are not getting oxygen, which often registers as pain. And we are hearing crackles, and she has a little bit of a fever. Those could be connected, though, to the infection. But the other answer is dehydration, because she has pale and dry mucous membranes and only fair skin turgor. Also, her heart rate is, we have her blood pressure probably a little lower than we would like. So, two things that could have caused her sickle cell crisis are dehydration and infection. Those would be kind of the first places we'd look to try and figure out how to proceed with her care. So in the emergency department, we start an IV and administer 5% dextrose in half normal saline at 125 milliliters an hour. And why do you think that type of fluid was ordered? What tonicity is it? Isotonic, hypotonic, or hypertonic? Iso, hypo, or hyper? Well, this can be a little tricky because it does contain dextrose. So, right, they're in a hypertonic state right now because they're dehydrated, and with this, remember this has dextrose, so the body's going to first metabolize the dextrose, so they're getting a little bit of extra fuel. And what's left is half normal saline, which by itself is hypotonic. And hypotonic fluids will push fluid where? Into the cell or out of the cell? It's going to go into the cell, and we would want that with sickle cell because we want to plump those cells back up. We want to unsickle them and make them round again. So that's kind of just why that particular type of fluid was ordered. We also would want to administer oxygen at 6 liters per minute with Venturi mask. That's going to be the most precise way to administer oxygen with the Venti mask. And we want to make sure she's getting enough oxygen, is not only could that our oxygenation be affected by her sickle cell, she's also has a recent history of a respiratory condition. So we'd want to be making sure she's getting enough oxygen. And give the morphine 2 milligrams IV, help control her pain, and administer 650 milligrams of acetaminophen or Tylenol. So of these measures, which would be the highest priority for the nurse to administer? What do you think? Well, remember the fluids are also going to help to break up her bring something up here. The occlusion, something closer. But if the oxygen is going to help to help her have to work less for breathing, give her more oxygen to her tissues for her unsickled cells to carry around, because not all of them are going to be sickled at the same time. It depends on the patient's condition and the patient's disease, how many of their cells are likely to sickle at any particular time. And that's when we're starting the supplemental oxygen, that's going to help to correct any oxygen deficit. IV fluids are going to help replenish your hydration and break up any occlusion from the sickled cells. So those will help as well. So we get some lab work back. We want to look at which of these could be related to her condition. Some of them might still be abnormal, but some may not be related to her condition. So her hemoglobin being 9.8, yep, because we're dealing with an abnormality of hemoglobin with sickle cell, or with red blood cells. So her hemoglobin could be abnormal because of her sickle cell. What about the hematocrit? Yep, that could also be related to her sickle cell disease. How about the red blood cells? That is low. The red blood cells are low. That could be connected to her sickle cell disease. And the WBCs are high. You might think, well, sickle cell is a disease of the red blood cells, which it is. But remember, we determined with what we have right now that infection could likely have triggered her her vaso-occlusive crisis. So we could connect the white blood cells because of her infection that led to the crisis. So, and we threw in a ABG for fun. Funsies. Oh, so the BICARB, I couldn't think of the word for a second. High, low, or normal? Yeah, they're actually the bicarb, the carbon dioxide, and the pH are normal. In this case, though, before when we were doing ABGs, we have said, oh, we don't need the oxygen to solve the ABG. But here that oxygen is important because it's showing a very low level of oxygen in the arterial blood, which is the blood that has just been oxygenated from the lungs. So this could also be connected to her condition because of the low oxygen from the sickling. So in this case, we would select the hemoglobin, hematocrit, red blood cell, white blood cell, and the oxygen from the ABG. And when you run into a question like this, it could be a select all that apply. Might want to look at each answer choice and say, if I could only select one answer, would I choose this? Well, remember with sickling, they're blocking blood flow to an area. So then those areas past the occlusion are not getting oxygenated. And this patient had several visible areas up to her assessment. Her ankles, knees, wrists, and elbows were swollen, painful, and warm to the touch. So she's got multiple occlusions going on here. So there are multiple areas where the blood cannot get. And some of that those are just in the joints. There could be sickling elsewhere. Is this oxygen level we'd expect to be closer to 100, especially if this is the arterial blood just coming from the lungs. So we would expect this number to be higher. And so if she's not getting enough oxygen because of the sickling, because there could be more blockages that we can't see evidence of on the outside that could be connected to her sickling, the low oxygen level here. So we get some orders, and let's look at which, over that part. So she's transferred to the medical unit where the hospital physician leaves additional orders, and we want to look at which ones would be appropriate to implement in her care. Would we want to administer 3 units of packed red blood cells? Would that help a patient with sickle cell?
No.
That administering packed red blood cells wouldn't help someone who is in sickle cell crisis because they have enough blood cells. They're just the wrong shape. So what we need to do is unsickle her cells, because if we were to give a blood transfusion, then unsickle her cells, she'd have too many red blood cells. So we don't want to administer the packed red blood cells. That would not be an appropriate order for someone with sickle cell disease. But with a VL's condition, knowing that she has a history of infection, would you want to administer Ancef, which is an antibiotic? And we were given her fluids earlier. We were giving her the 5% dextrose with the half normal saline. That would help pump them up a little bit, but we also want to break up any of the occlusions that have occurred so that the correct or the non-sickled cells could help circulate them more. But how about the antibiotic? Would that be appropriate care or appropriate order for VL with her current condition and history? Yes, because she has the high white blood cells and we know she has a recent history of respiratory infection. How about assessing her lung sounds and respiratory status every 4 hours? Is that something we'd want to do for her? Yes. Because we know she's had crackles and she's had recent respiratory infection, so we want to make sure she doesn't start getting any worse. How about bed rest in a position of comfort? Could be elevated, could be any position that feels comfortable for her. About continuous pulse ox. Yes, because that can give us a lot of information in the moment. How about administering ferrous gluconate, 325 milligrams PO daily? Would that help this patient? No, because that's an iron supplement. She does not have iron deficiency anemia. How about insert a urinary catheter and monitor strict I's and O's? Well, is she having any evidence of a urinary issue? Did we have anything about that in her history? She would be getting fluids, but she doesn't have any evidence, based on what we know right now, of any urinary issues where we would need, where she wouldn't be able to make urine on her own. So remembering that having a urinary catheter put in could be a risk for developing a UTI in and of itself. If we have a patient who's able to make urine on their own, then we may not need the urinary catheter. If something were to happen where she was not able to make urine because of her condition, like say one of the vessels that feeds the kidneys got an occlusion and no blood flow was getting to the kidneys, then we might have to do something else to get any fluids out. But when the answer choice here kind of says something and something else, it all has to be correct for the answer choice to be correct, because as was stated, she's getting IV fluids, so monitoring her eyes and nose, might be a good idea because she's getting fluids, so we want to make sure, what goes in roughly equals what comes out, but we may not need the catheter at this point. How about keeping her NPO? What do you think? Would that help this patient? We don't have any evidence she's having any swallowing issues. We don't expect her to need to go to surgery or anything like that at this point. How about administering a patient-controlled analgesic pump with a loading dose of 5 milligrams of morphine and interval doses of 1 milligram with a 6-minute lockout? Right, because the sickling causes pain, so the patient-controlled analgesic will then let her administer the medication when she wants. Now, you may or may not be familiar with PCA pumps. It does not mean necessarily that they can sit there and push, and they'll get a dose every time. There usually is, as it says here, a 6-minute lockout. Not always a 6-minute, but there's some type of lockout where the earliest they could get another dose would be 6 minutes apart, even if they sit there and push the button for 6 solid minutes, which you don't imagine, but it could happen. But there are, safeguards in place to help work with that. And how about vital signs every 4 hours? Would that help this patient? It's to help monitor her condition. So for this one, we would want to administer antibiotic, like an Ansaf, assess lung sounds and respiratory status, rest in a position of comfort, continuous pulse ox, patient-controlled analgesic, and monitor her vital signs every 4 hours. Because the antibiotics are going to help combat infection. Assessing her lung sounds and respiratory status will let us know if her oxygenation is improving. Resting in a position of comfort will help with pain management, and continuous pulse ox will help to determine if her hypoxia is improving. And the PCA pump will help with pain management, and watching her vital signs will help to determine if her overall condition is improving. So if we look at some things that the nurse could do, we want to look at which would be the most appropriate to help control her pain. Would we want to apply a cold pack to her abdomen, teach her guided imagery and relaxation techniques, position her in Fowler's position with the knee hinge elevated on the bed, or divert her attention by asking what she'd like to watch on TV? And if A was a cold pack, B the guided imagery, C Fowler's position with the knee hinge elevated, or D distract her with the TV. Okay, vote for C. Some votes. For B. So with these, remember, we want to control her pain, but also not make the sickling any worse. And putting her in Fowler's position could help with breathing and oxygenation, but it says with the knee hinge elevated. So like on the bed, having the legs up when the patient's sitting up, so that knee joint on the bed would be engaged. So that could hold her legs in a certain position. That could worsen her sickling in that area if it's not already sickling there already, because we're holding her in a specific position. So actually with the guided imagery and relaxation, that might help her control her pain, and along with the medication, and she might even be able to go longer between dosages, and it gives her some power back as well. because sometimes it can feel very out of control, especially if we kind of know what triggered her sickling with the illness, but she wasn't able to necessarily control, catching a cold. Obviously this was pre-COVID, but things might feel out of control and she's in all this pain, and this is something she can do independently without the nurse, without, medication, to try and control her pain and give her some of the power back. But we are not, no nurse is an island. We have assistive personnel who work with us, and we want to look at what they could do for the patient. And we want to look at, could they record intake and output for A? Could they obtain vital signs for B? Could they interpret lab results for C? Could they do discharge teaching? D. Could they evaluate pain relief? E. Or could they pass food trays? F. So A would be INO, B vitals, C lab results, D discharge teaching, E pain relief, F pass food trays. Yep, remember what the scope of practice is for different members of the team, and for our UAPs, STNAs, they can record intake and output, they can obtain vitals, and pass food trays. They cannot interpret lab results, they cannot do any teaching, and they cannot evaluate pain relief. They could ask the patient, how's your pain, after you got medication, and they could let the nurse know or put that in the chart. Same thing with the vitals, but they couldn't determine whether they're in or out of range. So which treatments could be an option for VL to explore as her disease progresses? Hemodialysis, hydroxyurea, stem cell transplant, or frequent blood transfusions. What do you think? So with this, the stem cell transplant could help. Hydroxyurea or hydrea may increase the fetal hemoglobin in the blood, but it can lead to leukemia. So it's not recommended very widespread, but on occasion you may see it. Hemodialysis would not necessarily, it takes a while especially if the patient does not already have access, if they don't already have a fistula or some type of port. So we'd have to put in a port before they could go for dialysis. And then the blood transfusions would continue to interject more blood cells into the patient, which could then, once we unsickle the cells that are sickled, then they would have too many cells on board. So you might see some hydroxyurea, but that is kind of with an asterisk. This could lead to leukemia. But you could see a stem cell transplant as her disease were to progress. And for assessing her current understanding of the sickle cell disease, which of the following statements made by the patient indicates the need for further teaching? So A, I should alternate my activities with rest periods so I don't get so tired. B, I may use the Percocet until my pain can be controlled with acetaminophen. C, I should use iron supplements to increase the normal hemoglobin in my blood. D, I'll be sure to get the pneumovax and flu vaccines when I completely recover. You think this is a single answer? I got a few different answers. This question says, which of the following statements indicates a need for further teaching? So are we looking for the correct statement by the patient or the incorrect statement? We're looking for what the patient said that's incorrect. So could alternating her activities with rest periods help so she doesn't get so tired? That may help because that could give her body a chance to recover before kind of getting overloaded, which could lead to sickling. Choice B was I may use the Percocet, which is a pretty strong pain med, although not like the morphine that we talked about earlier, until the pain could be controlled with acetaminophen. That could work because it would be stepped down from the IV pain medication, but it'd still be stronger than just plain Tylenol until she got it more under control that she could just use plain Tylenol. So C is the incorrect statement, which is the correct answer. But because iron supplements in this case won't help in sickle cell disease because it won't help to increase normal hemoglobin. She has enough hemoglobin, just some of it is that hemoglobin S, which could form the sickling. And we would recommend someone with sickle cell disease get vaccinated to help prevent them from catching a disease which could trigger a sickling episode. So the statement that would require or would indicate a need for further teaching would be C. I should use iron supplements to increase normal hemoglobin in my blood because that would not affect her sickling. That is the end of the hematology case study. So we're going to talk about HIV here for a little bit. And this is a very broad overview of HIV. There's a lot more to it. But HIV is short for human immune deficiency virus. And this is a virus that takes over healthy cells and forces those cells to make more copies of the HIV virus. Then that virus will move on to other healthy cells, take them over, and the cycle continues. This could eventually lead to acquired immune deficiency syndrome, or AIDS. So if a person has AIDS, they have to have HIV in their system. But if a patient has HIV, they may not have progressed to AIDS. However, AIDS is diagnosed when two conditions are true, and one of which is going to be that the person has an HIV diagnosis. You can't develop AIDS if you do not have HIV in your system. The other thing is they have to have one or the other. Either they have HIV and their CD4 cells, which are a type of immune cells, are less than 200. An average healthy person usually has between 800 and 1,000 CD4 cells. That would be one way the patient with HIV could progress to AIDS, having HIV and their CD4 cells are less than 200. Or another way they could progress to AIDS would be having HIV and developing an opportunistic infection. And these are infections that other people's bodies may be able to control or that may not affect a healthy person at all. But somebody with this immunodeficiency virus is not going to have the capability of fighting this infection off. So when we come across a patient with HIV, we want to collect their history because we need to know how long have they had this disease, what have they been taking to control it, because they're often going to take a cocktail of medications or several together, and they can actually get to the point where their viral load is undetectable, where with our current techniques, we can't find it in their bloodstream. Now, it's still there. It doesn't mean the patient's cured, but we really can control it quite drastically in some cases. But we also want to do physical assessment because we want to be looking for those opportunistic infections, just we're talking about on the other page. They're quite a range. They could include protozoal infections, fungal, bacterial, or viral. And patient with HIV is also could be more prone to developing some malignancies like Kaposi sarcoma, malignant lymphomas, invasive cancers, or human papillomavirus (HPV). It could have endocrine complications, and we want to be looking at their psychosocial assessment because having HIV can feel very isolating. And so we want, to support them with the support and services that they need while they're in the hospital and make sure they have what they need as they're looking at discharge. There are also other labs that we would run for our patient with HIV. And some of these are going to be a CBC, because we want to look at their lymphocyte counts, a CD4 and CD8 count. These are types of T cells, which are part of the immune system. And as we said, one of the ways we can determine if a patient with HIV has progressed into AIDS is looking at the amount of CD4 cells that they have in their body. So that gives us a comparison point. We also could run some antibody tests to check for any reaction the body has to the virus. Some older tests that you might come across are the ELISA or the Western blot, but the newer fourth generation tests are more specific. And these can include the HIV assays, which are positive in 21 days, that can detect the presence of the P24 antigen in 14 days. And so what this means is that they can get accurate results faster, these fourth generation tests, than some of the older ones. And so that can just help us diagnose the patient faster, and then the patient knows and we can start treatment faster, because that the reduced window period is helpful, because otherwise the patient might think, well, I haven't heard anything, so I bet I'm negative, and then they keep doing their lifestyle that they had before, and they could actually be spreading the virus without realizing it. There's also viral load testing, which is separate from antibody testing, but it's where we try to determine how much of the virus is in the body. And that can be detected about 10 days after infection, and it usually comes back in about 24 hours. Again, with the right medication cocktail, the viral load could actually be reduced where we can't detect it, but it is still there. Other tests that might be helpful include the CDC, like we said up above, for infection risk, stool testing. That's a little bit different than school testing. Biopsies, checking for, as we said, someone with HIV could develop malignancies, and also TB or tuberculosis testing through the skin test, tuberculosis skin test or PPD, or one of the blood tests like the quantiferon gold test, because people with HIV are prone to developing tuberculosis, and it's going to be really hard to treat because they're already immunocompromised. So we just want to be watching for that as well. As someone with HIV, they can have quite a complex condition. So some things we want to do to help the patient, we want to prevent infection, because they're going to have a lot harder road if they develop something on top of the HIV, even like a cold, like we were talking about with VL earlier. That could be a lot worse for them. Enhanced gas exchange, if that is an issue for them. Managing pain, enhanced nutrition, so that they can have as strong a foundation as possible. Minimize diarrhea. Not only could that lead to fluid and nutrient loss, but it can also be damaging to the skin. And we want to, as it says next one down, restore skin integrity, because that's one of the best defenses, or first defenses to infection, is intact skin. Also enhance their cognition. They can develop some mental status changes as their disease progresses, as well as any psychosocial issues, with just having the condition. People might not want to be around them, unfortunately, and so that can feel really isolating on top of everything else they're dealing with. And just to touch on opportunistic infections here for a moment, this is an example of Kaposi sarcoma. And opportunistic infections can include protozoal, fungal, bacterial, viral infections. So this is just one of several. And the impaired immune system also increases the risk of some malignancies or cancerous conditions to develop, such as Kaposi sarcoma, as we see here. Malignant lymphomas or cancers in other areas, such as cervical cancer, lung cancer, cancer of the GI tract, or the anal cancers. Could also be complications. So HIV could lead to a lot of other things. We have a case study here for a patient with HIV. And this is JJ, a 29-year-old accountant who lives with her mother. She was diagnosed as HIV positive 11 years ago and has been under close medical supervision. The past 2 weeks, she's developed persistent fever, recurrent night sweats, chronic diarrhea, and pulmonary infiltrates. And she's admitted to your nursing unit with fever, chills, chest pain, dry, non-productive cough, watery diarrhea, abdominal pain, nausea, fatigue, and malaise. And her admission's vital signs are as follows: blood pressure 98/62, heart rate 106 and regular, respiratory rate 28, and labored, temperature 102.8 or 39.3 Celsius. She's 5'6" tall, weighs under 4 pounds, and after some testing, she was diagnosed with oral candidus, Kaposi sarcoma, and pneumocystis cerevisiae pneumonia, or PCP. And when JJ was diagnosed as HIV positive, she did not decline treatment with antiretroviral therapy at the time. She did not tell her partner she was about her condition and continued unprotected sexual intercourse with him, thinking if she was HIV positive, he was as well. But several years later, her boyfriend developed AIDS and died 3 years ago. And she tells you she thinks it's her turn now, and she deserves what's happened to her because she engaged in premarital sexual activity. So there can be a big emotional component, especially with HIV. But we review her lab tests performed on JJ on admission. And what do you think would be most likely to be present with knowing her history? Do you think she could have a CD4 count of 150? Yes, that could be showing us something about her HIV. How about her white blood cells 3000? It should be elevated, but in some cases, especially with immunodeficiency, it may not be. Would her sodium level be affected by her condition? Yep, and white blood cell can drop with HIV because it's immunodeficiency virus. Not going to get the answer to that one, but do you think it's likely her sodium would be impacted with her condition? Well, 135 to 145 would be the sodium range, so it's actually normal. But how about her oxygen saturation? Would that be connected to her condition? Including her symptoms of the non-productive cough or chills. So in this case, the CD4 count, the white blood cell count, and the oxygen saturation could be, the CD4 and the white blood cell count could be connected to HIV. The oxygen saturation could be connected to her respiratory issue. So do we think she has progressed into AIDS? And so she is diagnosed with AIDS because she met certain criteria. And see, looking at these here, A, CD4 count less than 200 cells. B, B cell count less than 400 cells. C, oral candidus. D, pneumocystis cerevisiae, don't quote me on that pronunciation, pneumonia. E, MRSA, or F, hypoxemia. Which of these did she meet? Select all that apply. Do you think she met A, B, C, D, E, or F? Only A? Could she have met any others? Yep, A, C, and D. Her CD4 count was low. So by that and having a diagnosis of HIV, she's already progressed to AIDS. But remember, with a select all, you want to read all the answers. She also has evidence of some opportunistic infections with the oral candidiasis and the pneumonia. So actually B, no, because B cells are not involved with HIV. I just put that in there to have another type of cell. So someone progresses into AIDS if they have HIV and their CD4 count is less than 200, or they have HIV and they develop at least one opportunistic infection. So she's actually meeting all of the criteria for progressing into AIDS. And HIV or AIDS patients are often leukopenic, low white blood cell count, which can be less than 3,500. So in someone with HIV, if you see a really low white blood cell count, that could still mean infection. So we want to look at what interventions could be helpful for JJ. But A, assessing her lungs, skin, and abdomen every 4 hours and it's needed. Would that be helpful? Yes. We want to keep her respiratory system stable, and we know her skin needs to stay intact and some abdominal organs could be affected. About cleansing her mouth with a soft bristled toothbrush 3 times a day. Yes, as we want to, the mouth can actually be a big source of infection, unfortunately. Elevating the head of the bed 30 to 45 degrees. Yes. How about encourage coughing and deep breathing every 2 hours? Yes. So far we've got all of them. How about encourage oral fluids? And that could help rehydrate her a little bit. Also help thin out some of the secretions. How about maintain complete bed rest? Not necessarily. We don't have any evidence that she's having any mobility issues, so she wouldn't necessarily need complete bed rest. How about monitor intake and output every shift? Yes, because we want to make sure again what comes out is roughly equal to what went in. That tells us she's a good fluid balance. How about monitor her vital signs daily? Remember what, right? More than daily. Remember to read the entire answer choice. Because sometimes we like to hide words at the end that can change certain things. Now, if you're reading monitor vital signs, yeah, we want to do that, but then, once a day. That changes it. Right. Fairly frequently, usually at least every 4 hours, but you can definitely do it more often. How about provide a dim, quiet environment? It may or may not help. We don't have any evidence she's having any mental cognition issues right now that could help with. So it may not be something that we would institute unless it was per her request. About a regular diet. She may need, especially with the oral candidiasis, to have and a protein to help with her healing from the condition. So it may not be regular diet, How about rinsing her mouth with an alcohol-containing mouthwash every 2 hours? No, right? Yeah, you guys do that one. Because that's really going to dry out her mouth and can actually lead to more issues. How about using a protective skin cream to her perirectal area? Was that out for the alcohol-containing mouthwash or the skin cream? Yes, the protective skin cream is going to help protect her peri area, which could become irritated or even develop some breakdown from her stool or bowel movements. How about wearing gloves and gown for all patient contact? All right, that one's actually no, because as we said, having HIV or AIDS could actually be very isolating. So you want to be using your PPE when it's appropriate. Like if you're going in to help the patient get cleaned up or do a bed change where there could be, fluids in the bed. That's one situation. Dropping off their food tray, less likely to run into bodily fluids in the condition, and so it's sometimes good for the patients not to necessarily feel isolated by seeing people in PPE all the time. So for this one, we'd want the first 5: assess their lung, skin, and abdomen, cleanse the mouth with a soft bristled toothbrush, head of the bed to 30 to 45 degrees, encourage deep breathing, coughing every 2 hours, oral fluids. Then we'd want monitor INO every shift, and use the protective skin cream to the perirectal area. So now we want to look at the opportunistic infections. So we have some characteristics here. Here's one that commonly affects the skin, has firm, flat, raised, or nodular lesions, is caused by human herpes virus 8, is treated by antiretroviral therapy, chemotherapy, radiation, and or cryotherapy, and can cause lymphedema and disfigurement. What one do you think that might be? Well, we looked at a picture of it earlier. It's 2 parts name. Yep, Kaposi sarcoma is some things that give it away: firm, flat, raised, or nodular lesions on the skin. So the picture we saw had a lot of reddish lesions, but it might look similar to that. And another one causes difficulty swallowing, leads to white or yellow patches in her mouth, and leads to mouth pain. This opportunistic infection could be thrush or candidus, oral candidus. So as we're caring for JJ, she asks if it's too late to start medications for HIV since she didn't take them when she was just HIV positive before the AIDS was diagnosed. We answer based on knowledge that A, when AIDS was established as a diagnosis, so when she progressed to that, the drugs have not been shown to prolong or improve her quality of life. B, the severity of the drugs limits their use to patients who are so immunosuppressed that they develop opportunistic infections. C, the combination therapy with these drugs is recommended only when HIV patients are asymptomatic but have T cell levels below 500. Or the combination therapy with at least 3 drugs should be given to HIV patients who have an AIDS-defining illness, such as an opportunistic infection, or have a CD4 count less than 350. Anything, A, B, C, or D? It is actually D. The current guidelines for the antiretroviral therapy recommends their use in patients who have an AIDS-defining illness and or a CD4 count of less than 350 cells. And combination therapy is recommended with at least 3 antiretroviral drugs from 2 different classes. This is currently the most effective means we have of suppressing HIV. So I'm going to talk briefly about oncology and then do a short case study. So again, oncology is very, very broad because you could have almost any type of cancer of any part of the body. So we're talking in very generalized terms here. May develop in any organ or tissue and destroys normal tissue, which decreases function of that organ. But even when cancers occur in non-vital tissues or organs, they could still cause death by metastasizing or transferring into other vital organs and disrupting physiologic processes. Oncology is defined as the uncontrolled division of abnormal cells in the body. And so we all have cells that grow and split throughout our body, some faster than others, but they have a point where they stop. And tumors or cancers, they don't stop. They keep going. And we don't know why in every patient. Sometimes we can identify something, sometimes we can't. But treatments may include surgery, radiation, chemotherapy, or medications like biologic response modifiers, or BRMs. So to look at surgery, this is the first possible treatment. The thing to remember is that any organ loss reduces function. So even if we're removing a cancerous part of the organ, the patient still has to deal with lower than normal function of that organ. Surgery may be used in conjunction with other therapies, and then they have different types or classifications of surgical procedures. It can include prophylactic or preventative surgery, such as if a patient had breast cancer, say in the left breast, the patient may decide to have both breasts removed. Removal of the right breast would be prophylactic because the tumor, if initially was only found on the left, but they removed both, the right would be prophylactic. You could also have diagnostic surgery where they're trying to examine or get a sample for testing because maybe they aren't able to see enough on imaging studies or they need to take a sample for a biopsy. Curative surgery is where all the cancer tissue is removed. So it's considered a cure because all that cancer tissue is now left the body. Cytoreductive is also known as debulking, or removing part of the cancerous tissue. This may be used where the tumor is someplace that surgery can't reach all of it, or it's around an organ where we can't cut the tumor out without taking a vital organ. So we're removing part of the bulk, and then they could use other treatments to shrink what was left. There's also palliative, where we are trying to control the symptoms, like a patient who has a tumor that's pushing on their airway. Maybe we can't completely remove it, but we can remove enough that they're going to be able to breathe more easily. There's also a second look, make sure they've got everything. And rehabilitative increases function. Now, other forms of treatment for cancer could also be radiation, and this is just a sample of some of the different types, but radiation is defined as the use of radionuclides, ionizing radiation beams, or discrete gamma ray sources to treat cancer. The type of radiation delivery may vary depending on the patient's health, the shape, size, and location of the tumor. And this is where you may see a patient with some markings on their body where you're told, don't wash those off because that's where the radiation is going to be targeted. So here it's still coming from outside, but we can direct it to certain spots on the body. There's usually two forms of administration. There's teletherapy, is radiation delivered from a source outside the patient, like teletherapy, telephone. Then there's brachytherapy, which is radiation delivered from inside the patient, where they put an implant in. And I guess to me, the letter B, especially a capital B, looks like you could kind of put something in that, if that helps. And the patient receiving brachytherapy may be emitting radiation while the implant is in place. Potential side effects of radiation can include skin changes, hair loss, altered taste sensation, and overall fatigue. Remember, radiation is where we can target it or direct it to a certain spot, and this picture kind of shows the strength of certain types of radiation, but there's also chemotherapy. Now, the thing here is that chemo is more systemic because we put it through the whole body, but it is the treatment of cancer with chemical agents. And these agents have some selectivity for killing cancer cells over normal cells, but they only have some selectivity with that. And effects are more systemic overall, but the chemo is more likely to kill metastatic cells, so cells that are moving from one place to another. The IV chemotherapy route is the most common, but it may be given orally. You may hear patients on oral chemo, maybe in pill form, but this is an example of extravasation where the chemo medicine leaked out of the IV into the tissues. And as you can see here, some of these meds are very, very harsh, and so they can cause extensive damage to the tissues if they're in an area other than where we need for them to go. Some side effects can include bone marrow suppression, anemia, skin changes, neutropenia, anxiety, thrombocytopenia, sleep disturbances, nausea and vomiting, altered bowel function, alopecia, cognitive changes, mucositis, and peripheral neuropathy. So these meds are pretty strong and pretty harsh. The patients are going to be dealing with a lot from their illness on top of side effects of their treatment as well. So I want to look at the oncology case study here. And this deals with RJ, who is a 47-year-old rancher, comes in for his annual exam. And he's always been healthy, but comes in at his wife's insistence because his father had hypertension and died of a stroke at 59. His medical record indicates he does not smoke, has 3 to 4 alcoholic drinks a week, and has 4 work injuries that's resolved without any residual effects. He limits his fat and sodium intake, and his blood pressure has been normal. And he's married, has 2 sons who work with him on the ranch. But when reviewing his history, we asked how he's been feeling, and he said he just must be getting old because he just doesn't have the energy, and he's tired all the time. He says he's lost about 10 pounds in the last several months. Doesn't seem to be able to eat without feeling full. He's been able to keep up with his work, but finds it a little bit of a struggle and relies on his sons to do some of the extra work. And his physical exam reveals an enlarged spleen, pale conjunctiva and oral mucosa, and pallor to his skin. He's 5'11", 5 feet 11 inches tall, weighs 162 pounds. And this is actually a loss of 12 pounds since his last visit. And so blood is drawn for a CBC and chemistry panel, and we ask him to come back the next day. And he ends up being diagnosed with chronic myelogenous leukemia. So we talked about leukemia earlier. So this is a case where it's a blood condition, but also a cancer. And this is based on his CBC and bone marrow exam, including a study of his bone marrow cells. So I want to look at what would be consistent with a patient developing leukemia. So would his hemoglobin of 11.2 for A, would that be consistent with leukemia? B, his hematocrit of 50%. C, his platelets of 100,000. D, red blood cells. Immature white blood cells for E, or bone marrow with myelofibrosis for F. And these are select all that apply. So we have a vote for D. Let's say D is one of them, but there's 3 others. I'm going to vote for C. Yeah, C is another one. So we've got 2 more. Right now we have the platelets 100,000 and RBCs 3.5. Another one's E, the immature white blood cells. So there's 1 more. It would actually, I'll give it that one. Interest time is the hemoglobin. So to diagnose leukemia, they'll usually do a bone marrow biopsy and look for increased immature white blood cells. We add for E. decreased mature white blood cells. That wasn't on here, but so we see increase in immature, decreased mature white blood cell counts, decreased red blood cell count, and decreased platelets. So the oncologist explains treatments that could be used, including stem cell treatments, interferon, or investigative options. He doesn't have any sibling or family members that could be an HLA match. This is a type of match for bone marrow that we look for. The higher the match, the greater likelihood the body will accept it and not reject it. So close family members are likely to be the closest match, but it also could be somebody you don't know. And after weighing all of the options, risks, and outcomes, he and his family decided the oncologist he's going to start a medication called imatinib or Gleevec. So we want to look at, so he's to return home after therapy. We want to look at the most appropriate discharge instructions. So how about A, the patient should always receive all available vaccinations? What do you think? Right. That would actually be no, because the word always, remember, that's usually a red flag. And there'd be many vaccinations, but not necessarily all of them, depending on what it is. About B, exam skin and mouth for bruising or blood-filled blisters daily. That has too many B's in it. Yes, as we want to track any injuries that are occurring. About C, scheduled appointments for periodic blood testing that could be for the rest of his life. Yes, that's another one. Again, to track the progression of his disease. About C, suggest involvement in a survivor network or support group to help him and his family adapt to living with a life-threatening illness. It's just to help him and his family cope and see that yes, they have some extra things to keep track of, but that he can absolutely have a high quality of life. I'm going to encourage him to maintain his usual lifestyle patterns as closely as possible. Yeah. And it says as closely as possible. He is in a high-risk job, but hopefully his sons, who already are apparently experienced with what's going on his ranch, are able to pick up more of the slack, and hopefully he can still do some things, but probably not as much as he was used to. Contact with individuals with infections or recent live virus vaccines should be avoided. Well, people who have an infection or the live virus vaccines, because not all vaccines contain dead cells, some are weakened, and so any of those we'd want the patient to avoid, because we know he's more prone to infection. About encourage him to contact his healthcare provider if any new clinical symptoms occur. Yes, that's charting the progression of his disease. About H, teach his wife to administer the medication in the event he cannot administer it himself. It is oral, but just that she would know how to give it, if it needed food or not, or any side effects to watch for. What if they miss a dose? Just so that a second person is taught as a backup. It was just it's a good idea to teach a patient and a family member how to give a medication, just in case, so that there's a backup. But an oral medication you would typically have to swallow, but just showing that we want to have someone as a backup for a medication, especially if there's not a healthcare provider there all the time. So he has a complete remission following his therapy. So we want to talk about what that means. About A, he has a high chance of attaining a cure because the disease has been eliminated. B, he has no signs of illness, but cells with the Philadelphia chromosome are present. C, the peripheral blood is normal, but there's still evidence of disease in the bone marrow. Or D, the bone marrow and the peripheral blood appear normal and his spleen has returned to normal size. This one is D, because remission usually means all evidence of the disease is absent, but it doesn't mean it's been eliminated. Unfortunately, all it takes is one microscopic cancer cell floating around in the body to have a relapse. So a Philadelphia chromosome is where certain genes combine to produce a protein called tyrosine kinase, which promotes the development of some cancers, but not necessarily related here. And remission would not include evidence of the disease in the bone marrow. So choice C says peripheral blood is normal, but there's still disease in the bone marrow. Remission would be bone marrow and the peripheral blood are normal, and the spleen has returned to normal. So unfortunately, after 6 months of remission, he does have a relapse. He discusses treatment options, and patient, family, and oncologist agree a stem cell transplant is the best option for cure at this point. So if we're going to replace the stem cells, these are cells in the body that can grow into any type of cell. So it's kind of rebooting his immune system. But in order to do that, we have to wipe out his old one. So he has to receive whole body radiation and high dose chemotherapy to prepare him for the stem cell transplant. And he remains hospitalized during this time until he can receive the transfusion. And we want to look at what could we have the unlicensed assistive personnel do to assist him. Would they screen visitors for communicable disease, A? B, instruct the patients and visitors about hand washing. C, assist the patient with oral care and hygiene. Or D, assess the patient for signs of infection such as confusion or fatigue. Right, C, assist him with oral care and fatigue. As looking at the scope of practice, UAP are not permitted to assess patients or visitors. They cannot teach even about hand washing, and they cannot assess. So while, yes, we would want to screen the patients for communicable disease because his immune system has been wiped out, that wouldn't be a UAP. And we'd want to teach the patients and visitors by hand washing and watch for any signs for the patient of infection because we know his immune system has been wiped out. And he responds well to the bone marrow transplant, but he does have a relapse, unfortunately, after 1 year of remission. And several types of chemotherapy are tried, but he does not respond. And so RJ and his family request that hospice treatment be stopped and hospice be started. So unfortunately, he did have a relapse, but hospice gives a high quality of care for him and lives out his remaining time, in as much comfort and dignity as possible. Just an aside is that you might hear palliative care. That's hospice is a type of palliative care, but palliative care is not hospice care. Hospice care is, symptom management and maintaining the patient's comfort for as long as possible with a time frame. They have to have a diagnosis, usually terminal, within 6 months. But someone who's on palliative care is receiving the same type of care, but without a time frame attached. So you might come across that in the hospital, and it's just something if it comes up, I talk about it with my students because patients hear palliative and they think hospice, but that's not necessarily the case, but they can still get a lot of benefit from that type of care. So that is all I have for this evening. You guys have any questions while we're here? Okay, take that as a no. Have a good evening, guys. Good luck. If anything comes up while you're studying, please feel free to shoot me an email. Been a long day, huh?